Thank you for tuning in today for another program of Glory Bound. We are here to share the gospel of Jesus Christ through the preaching of God's holy word and Christ-centered music. Our desire is to encourage and uplift those that need a special touch from our Savior. Join us now for another blessed program of Glory Bound.
Today, the topic of our program is Reid Health Hospice. I wanted to do something in memory of Bud, and I thought, what better way is, let's do a subject on hospice, and let's get information out there as to what exactly do they do. I found when we used hospice for my husband, there were things that I did not know, things I found out, and I thought, I'm sure there's folks out there that have questions just like I did, and maybe you've been misinformed on some things. So we have three wonderful guests with us from Reid Health Hospice, and they're going to give out a lot of information today. So get ready. You might even want to get a pen and pencil and write some of this down, so you don't forget, because I know, like me, I forget a lot of things. But anyway, I'm going to have each one introduce themselves. That way I don't mess up their names, because all three are very important with hospice. And so we're going to start with Rick, who's right here next to me. I'm going to let him introduce himself, and, he can say what he would like at this time.
Okay. Well, my name is Rick Alvey. I am the chaplain on the hospice team, and I provide spiritual emotional support. I'm just there with families to be able to give them as much peace of mind as they can during the most difficult part of the journey of life. I also work some with our volunteers that go out and do things for our folks, and I do the grief support, bereavement follow-up with folks, do a couple of grief groups and a couple of memorial services every year that we provide for hospice families so that they can remember and celebrate their loved one, and that's my role.
My name is Melanie Vredeveld. I am the clinical manager with Reid Hospice. So I oversee daily operations, but I also go out and do admissions and speak with our families and help clarify misconceptions. So I am very excited to be here today to hopefully be able to clear up some things that maybe people don't understand or don't know about hospice. So thank you.
And my name is Brittany Ullery. I'm one of the social workers on the hospice team. My role, I kind of am here for a wide variety of support. A lot of time varies and more just meeting with the family and the patient emotionally and helping them process, being available for additional community supports. It really, like I said, kind of depends on patient and family needs as to why I'm there, but a lot of times it's just making that connection and providing that ear and just sitting with them through the journey.
Well, Brittany was one that did come to our house and make a visit, and it really was a blessing. My husband, he enjoyed every time someone came from hospice, whether it was a nurse or Brittany or whoever, he always sit and talk. It made it very pleasant. My question is to you, whichever would want to answer this, is who is hospice actually for?
I'll take it. So hospice is not only for our patient that we are providing services for, but hospice is largely for our families as well. So as Brittany was saying, we provide a lot of support to our families. Rick can speak on the after, the bereavement care, but we provide a lot of education to the families as well. So we are not only for our patient, but for our families.
I would also jump in real quick since we introduced ourselves. The one part of the team that didn't get represented today was home health aid. We have folks that will go and help provide patient care for the family, teach the family, help the family with that as well, and that's a part of the hospice process.
Okay. When you go into hospice, are you able to keep your doctor, or you provide all the medical needs
A little bit of both. You are able to choose an attending physician. So if you want to choose your primary care provider to remain involved in your care, you can. The hospice medical director and our nurse practitioner, they do oversee the care as well. That is their specialty. Our medical director had a fellowship and is board certified with hospice and palliative medication. So it's kind of his specialty in that area. So he provides care as well as the attending physician. So.
Okay.
Some people elect to not have their primary care physician involved, and that's perfectly acceptable. Hospice takes over all of the care.
Okay. And I find hospice pretty much supplies whatever your need is. I mean, whatever need of that patient is, which is really, that's nice. Because I was surprised, well, hey, I mentioned something, it would be not, we'll get it for you. Like there was a certain pillow or something just to make sitting easier. Or there, I mean, I was impressed because they were right on top of it. It wasn't, you didn't wait a week or 2 weeks, it was there. Whether that day or the day following, but it was there. And I find the nurses that came to us they were very cheerful and talkative, and you wonder that it's a difficult ministry dealing with patients that are sick, I would think. So I think it's a special calling. I don't know. Brittany, how did you get into hospice? Why did you choose hospice?
Actually, I think hospice chose me.
Okay.
I actually worked in another department in the hospital, and prior to hospice, I was one of those that didn't like to talk about death, dying. I avoided it, and I think something kind of shifted, and I was interested, and I kind of, I've been with hospice over 5 years now, and I love it. It just being a part of someone's life at the end of their journey is nothing. It's such a special time, and to be there for families and patients is, it's rewarding.
It's an honor.
It is. It is an honor and a privilege.
So, if you get into hospice, can you check yourself out and say, hey, I don't want to do this anymore?
You sure can. And it's a very easy process. We do have patients on occasion, does not happen very often, but we do have patients that will sometimes want to, try treatment again, or maybe have some specific testing and let me see where I'm at in this process. And so those patients that are adamant that they want to revoke, we call that a revocation out of hospice. It is a simple signature on a form. And then your Medicare or whatever insurance you have immediately goes back in like it would normally, and you're able to, seek those treatments or whatever the purpose would have been behind you wanting to disenroll.
And then are you able to come back into hospice again once you check out if you decide, whoa, I think I made a mistake, I need to go back?
You can.
Okay.
The ultimate decision there is our medical director, so that would be his final decision, but he would review the patient, why they disenrolled, the purpose behind it, and then we would just make sure that we had a really in-depth conversation so that the family and the patient understood where they were at within this journey and that they were ready to come back.
Kind of connected
Sure.
to that, we have folks that we call graduate out of hospice, and sometimes we'll have a patient that obviously the expectation is 6 months or less, so they come into hospice. Sometimes they've not been getting good nutrition, good health care, and we have patients that will come in and all of a sudden they're getting that balanced attention to the health care and nutrition and those types of things, and all of a sudden they're feeling better. And we'll occasionally have someone for longer than the 6 months, and they've kind of stabilized, and they'll graduate out of hospice because they just no longer need our services. So it doesn't happen very often, but it does. And again, they can come back in when their health declines, then they need it.
I think sometimes people, this is just my opinion, I think they think hospice a death sentence. And, once you're in hospice, you're going to die. But that's not true, necessarily.
No,
I mean,
I think all of healthcare has a dual focus. One is to help you feel better, cure what's wrong, and at the same time help you be as comfortable as possible with whatever you're dealing with. When you come to the process, to the point in the process where there's no longer a cure, there's nothing that's known that's going to help you correct what's wrong, then 100% of the focus becomes comfort. And so a lot of times, because people don't understand that, they will think, oh, you're just going into hospice, you're giving up, it's a death sentence, you're just trying to kill them off. That's not the case at all. We're just giving 100% of the focus on keeping them comfortable for whatever quality of life they can have for however long they're going to be with us. And ultimately, that's not in our hands. All we can do is make them as comfortable as possible.
Can I tag onto that just a little bit? With that being said, I agree wholeheartedly with everything Rick said. And I think one thing people don't always, think ahead of time, it's, oh, you're going into hospice, you're going to die. Actually, you're going to go into hospice and you're going to live your best life. Okay, so we all die. No one gets to escape death. We may not know how or when or what our situation will be, but that is the natural part of living, is death. We all will come full circle at some point. So I think when we're able to get to the acceptance portion of where we're at within that disease process as to what's going on, then that's when we choose hospice care and we choose to live our life the way we want to live it. So the focus is a little bit different. We're no longer focusing on our appointments and our labs and our testing and, all the invasive things that take time away from what's really important to us in those last weeks or months, the remaining time that the person has. So,
is there a timeline for how long you can stay in hospice?
So you have to be eligible. That's the only timeline per se. So for the initial hospice admission, you should be within a 6-month prognosis. So the physician feels at that point that you are in stage of whatever disease that you have or whatever's going on, and that you will pass within 6 months as long as there's no continued aggressive treatments or, interventions or life-sustaining things happening. So but we have people that way surpass that 6-month mark. We have recertification periods, and that's when our medical director will actually come to the home and see the patient face to face, talk with the family, and make sure that that patient still qualifies for the hospice criteria. And they do that every 60 days.
Oh,
so,
okay.
Yep.
Okay.
Yep.
Okay. Now, I know we did. I asked you this earlier. So we know Medicare takes care of hospice. It doesn't cost the patient anything. It goes through Medicare. But we have younger folks that perhaps are in hospice. You want to explain how their care is taken care of?
Yep. So they receive the same care that our older folks receive, and whatever insurance they have is what we would use. So if it is a Medicaid patient, so our elderly people tend to have Medicare for the most part, but our younger folks tend to have Medicaid or a private insurance, like say it's someone in their 20s or 30s that was working. But we are non-for-profit, so regardless of insurance or payer abilities, we still provide care to our patients.
Good. Good. That's good to know.
Yeah.
Okay, Brittany. So, where do you come in here? How often do you go see patients, or do you make regular visits to everyone that's in hospice?
Yeah, absolutely. It's my favorite part of the job is actually going to visit. So, because we have some families that kind of, again, depends on patient and family needs. I initially go out and make an initial visit, kind of assess needs, and then kind of go from there. Because a lot of times in the beginning, families and patients, it's overwhelming. You get a lot. You're just now coming on hospice, you're coming to terms with what's happening, and then you just it's a lot to process. So a lot of times I'll make that initial visit and at least follow up the next week. I have some patients I see weekly, some I see every few weeks. I have some patients that prefer just phone calls, but we all work collaboratively together. So if a nurse is out there and they see if there's something that I can be helpful with, they will communicate that to me and I will reach back out. Because like I had mentioned earlier, a lot of my support initially is kind of just processing, kind of going through the information, sometimes having those harder talks, because it may be the patient has accepted it, but the family's not there yet. And it's just answering questions and preparing them for what's going to happen, because I think if you're prepared, it takes that fear away, and a lot of times that fear can kind of cause, just a snowball effect. So at least, knowledge is power. So us providing that education and training ahead of time, and then just kind of being there with you through that journey. I also am here for, obviously with caregivers, making sure they're taking care of themselves, because a lot of times in that journey, when you're providing 24-hour support, you tend to not always take care of yourself because you're more focused on your loved one. So that's where I come in to make sure everything else is kind of, all those needs are met, helping reach out to additional resources. So I have some families that maybe don't have as great of care plan as far as caregiving support, so I can come in and help connect them to agencies, or we just kind of sit down and talk about what works for them if they need additional care in the home. We also offer respite care for caregiver relief in our program, and that's something we kind of discuss as well. And then I also can help with end-of-life planning, funeral planning, things that, those harder conversations. And then we also encourage, like I said, people to live their lives. So there are times where we have patients that travel outside of our area, and I help connect them. I've had patients that have traveled to Florida, to Texas, and if they're able to do so, I will find an agency in the place of their traveling and connect, so that way if they're outside of our service area, they have an agency and support available. We'll make sure they have all of their medications, any medical equipment they may need, because we want, again, if their goal is to go see the ocean one last time, we want to help fulfill that and make that happen for them. So it really, kind of just depends on what the family and patient's goals are.
So a patient's able to go and travel, even though
Absolutely.
they're in hospice?
Absolutely. If they're able to do so and safely can do so, like I said, I've had patients, I had one travel, they were on oxygen. So coordinating that oxygen to make sure they had what they need here and that they'll have what they need there. So absolutely. And we'll make sure if they need like a walker, a bedside commode, any of those things upon their travel. And we just help kind of coordinate that. And again, work alongside. We've actually had quite a few patients that have traveled and live their life.
You mentioned respite care. What is that to somebody who's never heard of that?
So respite care is for that caregiver relief. So we do offer that. And it's, for us, we utilize the hospital. We contract with 5 East, and we provide transportation if the patient is not able to transport by car. If family can bring them, that's absolutely fine. But essentially, I kind of word it, it's kind of like a hotel stay for the patient. They will be in their own room, kind of, we'll continue medications, meals, all their, that way. And then at the end of it, like I said, we provide transportation back. Not everybody utilizes it, but we do encourage it sometimes for caregiver relief, because like I said, when you're taking care of someone, it's a lot.
So the caregiver can get a break,
Absolutely.
and they could go into the hospital for a couple days if
It's up
there's
to 5
something
days.
that's going on in that caregiver's life, or say maybe they have a health situation or needs something done, or surgery or whatever.
Yep.
So then they're able, that's good to know. That's good to know,
Absolutely.
because, that can be kind of scary. Well, you know what, I need this done, but I can't because I'm taking care of this person. So there is something out there that you provide to give them a little bit of a break if they need it.
Absolutely. Yep.
But you say a lot of people do not use that?
Again, it kind of depends. A lot of times I think it's that guilt. A lot of times families just don't want to, or it's, the hospital, they don't want their loved one to go there. So it kind of just depends on the need, but we do encourage it, because a lot of times we will see things transpiring before it happens. So we're getting close to where, burnout's going to happen, or.
Yeah, I could see that. I could myself. Yeah, I probably would not. Because you want to be. I wanted to be right
Absolutely.
there with him and take care. Of course, we didn't have hospice all that long. Months. So it went quicker than I thought it would. But that is good information, and I think a lot of people don't realize that there is that option. There's something out there.
Well, we just used it recently for a gal who was taking her daughter to the East Coast to get started in graduate school.
Wow,
So it's not
okay.
always, it provides some relief for the caregiver, but a lot of times it's just there's other life events going on. They're going to go out of state for a wedding or something going on, and the patient's not able to make that trip, so it gives them an option to be able to be cared for while the family is at something else going on that's a special life event.
That is really good information. I think there's probably a lot of people that don't realize that there is that option.
Yeah.
Because you think, oh, they're in hospice, and you have them at home, and that's it for whatever months. You're kind of like, I don't want to say stuck, but you just can't do.
Absolutely.
Yeah,
absolutely.
So,
absolutely. And
yeah.
that's hard too. We always, I'll talk with families like all hands on deck. Anybody that you've got to be there to support, because it's until you're in it and doing it, it's 24/7.
So, when you go into hospice, pretty much all life-saving procedures or anything, that kind of stops. Is that correct?
That is correct. Yep.
What about, let me ask you this, what about dialysis? There's so many people that are on kidney dialysis anymore. So if they go into hospice, does that stop also?
They come into Reid Hospice, yes, it does stop.
Okay.
Dialysis is a life-sustaining measure. So hospice is big on focusing on the person and where their body's at. So if they're in a place that their kidneys are not functioning, we understand that, we respect that, and we do not, typically our patients are not on dialysis because that is life-sustaining. That's that extra intervention.
Oftentimes they go off dialysis.
Yes. And that's a big part too. We have patients that choose, they're either no longer tolerating it or they're exhausted and their day off from it is spent resting and trying to get feeling better, and they find themselves kind of in a cycle that they feel like they can't get out of just exhaustion and not being able to go and participate in life events and do what they want to do. So we do have patients that call and come to us because they are choosing to go ahead and stop their dialysis.
Okay.
Yep.
Okay, Chaplain Rick, do you pretty much go and see everyone that comes into hospice, that is, make a visit, or say you get somebody that's very involved in their church?
Sure.
Or is that an option?
Yes, I make contact with everybody who comes into hospice to have that initial, hey, here's who I am, my role on the team. It is entirely up to the patient and the family whether they want me to visit or not. Some folks have a great support from their own church and pastor, don't need chaplain support. So in those situations, we just kind of become an extra layer, an extra safety net. Still available. If they call the hospice office, I'm still available. I'm just not regularly visiting because they don't need that. Some folks don't have faith as a part of their journey, don't want an involvement from a chaplain, which is fine. I tell them I'm kind of just there to share the journey, be a support and encouragement, do anything but the dishes and the windows. So, if they just need somebody to sit and visit, talk, I love to hear stories. I love to ask people, and I try to create safe space for people to be as much at peace as they can with everything going on and support whatever faith they have. I support that in whatever way I can, but I try to focus on helping them, asking questions that reflect on the highs of their life and the joys and how full their life has been, because right at the moment, everything is hard and heavy at that season of life. But I get to ask, my favorite question to ask is, how did you all meet if it's a married couple? Because I just hear the most amazing. Earlier this morning, I was with a couple, and I asked the wife, how did you all meet? She said, we met, we were set up by our employer, and we got married on a plane. And I said, well, that's the first time I've heard that. So I get to hear just amazing stories, and people just light up when they relive their journey and all the things they got to share together. And so that's one of my joys. So it really is up to the family and the patient. I always make contact. If they want regular visits, I can visit as often as they want. If they don't want me involved in visiting, but then it comes to end of life and they want me to come and share scripture and pray with them, I do that. So it's whatever they need. I'm just kind of available as needed, as often as they want me to be involved.
Well, that's good ministry. And it's good for that, people can reach out Because, this is a time when they need some spiritual help, I'm sure, many times. So, okay, Melanie, how often do your nurses, they are RNs, correct, that come out, most of them, I
Our
believe?
case managers that are assigned to our patients are RNs. We do have one LPN that helps and does some team-based nursing, and she will do secondary or third visits through the week to kind of help out with that case manager. It also gives our patients and families another face that will be familiar in case that case manager is off. Maybe she's ill that day, maybe she's out on vacation. We still want to give families, we try to stay as consistent as possible, and we want to give them a familiar face.
So how often do they make visits? Say you have this patient, so how many times are you going to visit this patient in a week?
Every plan of care is individualized. So we see them at least once a week. Even if they're doing fabulous, they feel great, they have no complaints, we still have to come in and see them. We do a head-to-toe assessment, listen to heart and lungs, take vital signs, make sure everything's going, the way they would like for it to be going. And if so, then we move along pretty quickly and kind of get out of the way. But when our patients when we're starting to see decline or maybe their pain is increasing, we do increase our visits at that point too. So some of our patients are twice a week or 3 times a week. And then when we get to the end of the journey where we feel like our patients are pretty close to passing within a week or so, we start seeing them every day. We want to make sure that the family is supported. We want to make sure that the patient is comfortable. We're providing that education for medication administration because that is something families do. It's not just the hospice nurses that come in and give medication. The hospice nurses teach the families how to give that, when to give it, how much to give it, what they're looking for. As Brittany mentioned earlier, knowledge is power. So when we know what's coming, things don't seem so scary. So we try to do as much education with our families as we can.
And we're available to the family and patient 24/7.
Yes.
Round the clock, every day of the week.
Well, what if a patient, something comes up in the middle of the night, say at 2 o'clock in the morning?
We have an on-call phone number. So they call the on-call number, which goes to our hospital operator, and then they put that person through directly to an on-call nurse. So it doesn't work like an answering service. You're not leaving a message and waiting on a call back. There's not that tense in between, I don't know what to do moment. You are immediately connected to one of our RNs that are on call, and if they can walk you through something over the phone and answer your questions, they will. But most of the time, if someone's calling in the middle of the night, our nurses are going to do a visit just to make sure things are going okay.
Okay. Okay, I see we're winding down. We have about 2 minutes left. So let's just go right around. If there's a final statement or something you want to share.
I would just say I had lots of misunderstandings about hospice before I was involved. So if you have any questions at all, call the hospice office, and any of us would be glad to answer your questions.
Yes, I agree, Rick. I think for me, one of the most important things for me to want people to know is earlier is better. So when we get into hospice and we're actively dying, people, families included, families, patients, they don't truly get the full benefit of hospice at that point. They get a very rushed version. So, if we're having times where our family members are saying, hey, I don't want to go to the doctor anymore, I'm tired of the labs, whatever the situation may be, or maybe your doctor's had that quick conversation of, hey, let's start thinking about what our end goals are. I would strongly encourage people to at least call and let us come give them information. Because again, knowledge is power. So the sooner we get in, the better the care goes. And there's actually studies done that show patients on average live about 29 days longer once they get into hospice than patients that have the same disease process that continue with aggressive treatments. So early is better.
I don't know what to add to that because that's
Kind of covered it all, right?
I pretty much covered it all.
Yeah, well, good. Well, I tell you what, I know we're down to less than a minute, so I hope this program has helped you. I hope, if you had any questions, hopefully they got answered here today. I thank everyone, all 3 of these special guests, for coming and doing a program today. And I hope if you have that need, don't hesitate and call Reid Health Hospice. I'm telling you, they're there for you. I found that out personally, and they even follow up afterwards. It's They thought, and you say, yeah, I'm good. Chaplain Rick, he'll follow up. And they offer different meetings also that you can attend, for the spouse or the family that's left behind. So until next week, we will see you. Have a good day.
Thank you for watching Glory Bound. We hope you have enjoyed our program. If you have made any decision for Christ today or have any special prayer requests or questions, please contact us at 765-935-1435 or email us at hbcglorybound@gmail.com.